morning. Ahmedabad, whenever I come, for us it's synonymous. For the Department of Pediatric Surgery, it aims New Delhi as well as for the rest of the country. Ahmedabad is synonymous with Professor Amardeep Shah. I came there so many times when he was the head of pediatric surgery as examiner, and subsequently when he had meetings. I've seen Amar grow and establish a wonderful hospital here with very senior pediatricians around us. They have seen pediatrics grow and pediatric surgery grow. And my very dear colleagues and my national teacher, Professor Ravi Kumar and Dr. Redkar, who was in this institute several years ago and were training in pediatric nephrology. And I see her very often in international and national meetings. She has taken us through the journey of UTI, and in that umbrella, it looked as if VUR is one end in pathology. We as surgeons come across VUR up front, and it would seem to you that we are having jaundiced eye, but as a result of this, often I have tried to look at the lines presented by pediatric nephrologists and in between the lines presented by pediatric nephrologists to see together what is not very obvious. And with this background, I will tell one more thing, that VUR, I'm talking about primary vesicoureteric reflux, has been treated for 5 or 6 decades now, mostly on personal opinions. There are very few hard data which would establish that there are criteria could be built upon scientific basis. And it's not that it's a turf war between a pediatrician, nephrologist, or a urologist. It's the children we are treating. We are in the business of treating children and the kidney. So we have to look at it holistically. We are on the same side of the fence when we look at a child who is having illness. We have to look at the equipments and paraphernalia available to us, because we are custodians in time. We should not have turf war. And very elegantly, Dr. Kanikar has put all the literature available, very objectively, with full quotation, with full sincerity or honesty, as we know her. And so, there are no qualms as far as what I'm going to talk about. It will look contradictory in between, but if you go down the journey, it will look like we are all on the same boat. So, next please. I start with this because literature is so important and we are in the era of evidence-based medicine. Just give me, Amar, just tell me 3 minutes before I have to end, because we are starting a little late in sessions and sometimes I go a little deeper. Okay. So, many years ago, a very eminent pediatric urologist in the US, Jack Elder, he conducted a survey which American Academy of Pediatrics as well as American Urology Association are known to conduct surveys among the practicing pediatricians and pediatric urologists to see what are the practices. Most of the practices are based upon available evidence, but sometimes they are not able to do it that well because the evidences are not available. So they do surveys to take stock of the situation. This survey was conducted in which more than 3,000 papers were reviewed. 168 only were found to be of any use. They found only 3 prospective randomized controlled trials from which some data could be taken out. They summarized that only few recommendations can be derived purely from scientific evidence. This is the treatment of VUR grade 3+. Initial continuous antibiotic prophylaxis for most children is the general practice. Risk of pyelonephritis is 2 to 2.5 times higher in these children than the general population, and in grade 3+ reflux. Scarring increases the risk of hypertension. That was 1997. Now, it's a common condition, this primary VUR. 1% of children, normal children who go to a school, pick up 100 children, 1% would have VUR. And as Dr. Madhavi was telling, 1/3 of children and half the newborns or young infants who have documented UTI have VUR as the underlying cause. Up to 25% of children with VUR become the subject matter of renal replacement therapy. So it's a serious business. Just to touch base, this is the bladder. I'm actually cystogram. During emptying of the bladder, depending upon the grade of reflux, some urine will go up. In between emptying cycles, this urine will come down. It will stay till the next cycle. It will mix with urine, still coming back, the fresh urine. Invites infection, and this process goes on and on. That leads to UTI, that has a potential to pyelonephritis. Every pyelonephritis has a potential to become a scar, we don't know which. So UTI, pyelonephritis, renal scarring, decreased renal function, end-stage renal disease, development of hypertension. It stunts somatic growth. And one more thing, in a girl child, a scar forms, and again, I will keep quoting her because she has preceded me and she has shown so much literature, and it will also look that we are all together in the journey. A scar risks pregnancy years by recurrent abortions, small fertility babies, and preeclampsia. So this scar, the irony is, unless the scar forms, it does not become of any indication to stop reflux by intervention. We are not sent cases till scar forms because it's an indication. Look at this item. Current indications of surgery: appearance of a new scar, progression of existing scars, more than 2 UTIs in the last 6 months, each episode risking scar. Scar once formed is forever, and we are risking that girl for life as she grows up into problems which we just mentioned. Peritoneal fibrosis, which is scar, is a permanent process. It has a potential to cause atubular glomeruli. And as a result of this, it becomes an independent seat of production of certain hormones which are detrimental to the kidney, and we'll come to that part. So this is the pathogenesis. So when we treat VUR, what are our goals? Prevent renal injury, prevent symptomatic pyelonephritis, and other consequences which I have enumerated. We have certain modalities of treatment. Medical is one of them. Surgery, which was open, now has become robotic or laparoscopic, was the second option. Endoscopic was the third option, which is now finding higher place. And in a survey published in Journal of Urology and a very elegant study conducted in Europe by Paolo, which has shown very clearly that it's a preferential first treatment for reflux in children who have been diagnosed to have VUR and who have UTI by the parents. Now, this was a study which indoctrinated a generation of nephrologists because it was conducted by Jean Smelly, who was in the Institute of Child Health in England. She conducted very elegant studies of the era or that time. She questioned the practice of surgical intervention in VUR, which was proposed 50 years ago, or now 60 years ago, by Dr. Hodgson, who said that uretrovesical junction is abnormal. Urine shouldn't go up, should just go down, and it should be fixed by surgical intervention. She said that renal outcomes are no different between surgical intervention and between antibiotics. So why going for surgical intervention? And maybe she had apprehension because in those times surgical intervention was a big thing. There were not good antibiotics, it was an open surgery, and there were infections, etc. So the concern was very genuine probably, but she showed that the outcomes are not so different, so why going for such invasive management? Now look at the report. This was published in 2001. It had 2 arms. The first arm was European, published the first 5 years of study, and the second was American in the next 5 years. So they looked at follow-up 5 and 10 years. VUR with dilatation, without with dilatation, that is 3, 4, and 5. Without dilatation, grade 1 and 2. There will be very few grade 1s. And no reflux. They found that at the end of 5 years, only 15% patient will resolved, and at the end of 10 years, 50% had resolved, or 52% were still persistent. So, how you look at it? 50% children on antibiotic prophylaxis, grade 3 plus VUR, still had persistence of VUR. There are many more hidden information in that. If you look at that paper, they showed that the number of scars which were formed in the surgical group versus medical group were the same. So again, the result was equal. So why go for surgery? This trial probably tilted in favor of medical treatment. But the same article in the same journal added a box of commentary by the editor. And this editorial comment was from Billy S. Arendt, which Madam may be knowing, a very eminent pediatrician of those eras, still alive. He wrote down that although this is a paper with a trial report, the general experience with medical management, especially grade 3 to 5, was that these children continue on medical management with recurrent UTI, new or progressive scarring, subsequent development of hypertension, and go into chronic renal insufficiency. They questioned the study that they didn't have any control or comparison treatment groups, and their findings required validation. They had put the children into a medical treatment, and they sent for surgery only when the scars and other indications had built up, which I had mentioned. By that time, the kidney had got programmed. So end result was dictated by the insult which had taken place, and how this insult takes place in a sterile reflux, because they were supposed to have antibiotic, prophylaxis, and sterile urine. That is why they were kept on medical treatment. Despite that, damage was happening. The scars numbers were equal at the end of 10 years. But if you look deeper, and Amardeep must have gone deeper after I have pointed out so many times, that the number of the scars stopped after surgical intervention, but the scars continued during that 10-year period, throughout that period, sporadically. The numbers were small, but they ended up equal. But immediately after surgery, within first 2 years after surgery, the scar formation had stopped. So if you continue medical treatment beyond 10 years, we expect the scars will continue. There is a etopathogenesis behind it. If you have a pyelonephritis, which has the potential to form a scar, the scar will not be seen within the first few months, because what is the scar? The scar is a photopenic area. It's a negative thing, which is seen because the surrounding parenchyma grows. So when a surrounding parenchyma grows, it is picked up on an isotope DMSA scan, and you see a negative area, and we call it scar. It's a photopenic area. The growth of the parenchyma takes time. It takes minimum of 6 months. It may go up to 2 years, depending upon child's nutrition, etc. So therefore, there were some issues with this study. As I mentioned about the editorial, which was carried in the same article, another paper came in the same year from Great Ormond Street, London. Smelly et al. Had said there was no difference between boys and girls in terms of the spontaneous rates of resolution. And there was no relationship whether or not scar is present in terms of the rate of resolution. But the Maggie Gottlieb's paper was showed very clearly the infant boys with scars have a very poor prognosis. So it's not that they're equal, it's not that scar doesn't matter. Cochrane review came in 2011. They established that 40% children develop scars despite antibiotics. So obviously, data were building up, the observations were coming up, there were more objectivization, questioning the medical treatment, and they also established that a surgical treatment after surgery, even after 5 years, if we evaluate, more than 95-99% children would have no reflux. So why not stop reflux? It also reduces the incidence of pyelonephritis. So again, favoring that if you do intervention to stop reflux, it's intention to cure. But if you keep the children on antibiotic prophylaxis, it's intention to treat. You have to choose what you want to do. So shouldn't we stop reflux? Another paper which Dr. Bajpai had very elegantly quoted, and this was published a little earlier, 2003, in Archives of Disease in Childhood. They said, we're looking at these data, which were so confusing, that there's no firm basis in the literature how best to investigate patients with UTI, how best to treat VUR. Therefore, it's very questionable. What is the association between VUR, UTI, and kidney damage? And they went another leap forward and saying, is VUR a modifiable risk factor at all? Should we treat it at all? Forget about antibiotic prophylaxis, intervention, etc. Nothing is happening. Damage is going on. So where have we gone wrong? Children are getting damaged, recognized, they go into renal failure, they emerge in big numbers from VUR, which go into renal replacement therapy, and I ran into adult nephrologists and transplant surgeons. They often call me to give talks. The last with Dr. Madhuri was in Pune, where the Indian nephrologist have called her. She was a convener, and they have called me. And the convention report did not account for why is it so. At that time, the literature didn't take into account, as she said, bladder bowel dysfunction, which is dysfunction voiding also, role of sterile reflux. It was assumed it is not, it doesn't cause damage, but probably damage was happening, and we have to prove it. And the genetic influences, which are now center stage actually, and last two at least. So the paradigm shift started happening. Amar, I will have to, just let me know, because if you allow me to continue, I will do the way I am doing it, and I will definitely cross the time.
So you have 10 more minutes.
10 minutes, I try to finish. So with the time, there was a paradigm shift. There was better understanding of biology of renal damage. There were questions were raised about antibiotic usage, and endoscopic injection, as I said, started becoming center stage. A very good trial actually, which I will quote just now, is emerging as very informative. So let us look at this. What have we learned? Pyelonephritis occurs despite antibiotics. Long-term use has side effects. Nausea, vomiting, resistance, hepatitis media, etc. And this has even come in the 2014 first report of randomized intervention for VUR study, RI-VUR study, NEJM. The National Institute of Clinical Epidemiology in the UK guidance, they give guidance periodically on various conditions. They said prophylactic antibiotics do not reduce renal scarring in children less than 30 months of age who have grade 2 to grade 4 VUR. And as a result, they said you treat as they come with UTI. Now, we saw 2 or 3 very elegant cases described by Dr. Sankar. There were kids who were being investigated, and UTI was not as a first investigation because the children come with vague symptoms. They were treated by GPs and pediatricians who are not hardcore pediatric nephrologists, so the index of suspicion is very low. As a result of that, they continue to have UTI. So if we send a child without even prophylaxis, he is prone to renal injury, especially in the first 30 months of age, a time when he cannot scream and say, I have UTI, I have symptoms of burning, etc. So UTI is diagnosed 3 years and beyond as UTI symptom. These kids become sick, that's it. And unless you have a high index of suspicion, you will not know what is the underlying cause. This was a big hole in the NICE guidance, which I have summarized in 2 points. Infants have non-specific symptoms with UTI and greater risk of morbidity related to infection because those 30 months are very crucial after birth. The randomized interventions to your trial, as I said about the first 2-year report is only available now. The subsequent report will come in due course. They have established prophylaxis is better than surveillance. So it's not that you send them home like nice guidance, it helps. But only if given a short period. Now how do you define short period? This study has been published within the first 2 years the trial started, and by this time resistance has started. At the best you can say 2 years. And that it takes us some time before the report is submitted. So 1.5 to 2 years maximum is a short time. After that the problems start. Back again into this, because as I said, many of you during your training period who are now very senior pediatricians must have come across this IRS study, which guided all of us actually. And science is not truth, it is a search. With search is going on, so we have to move onwards. The terms of reference of our looking into the whole issue was 50% refluxing even at 10 years, scars found despite antibiotics. Is medical treatment safe enough? Which means, is sterile reflux safe? So, more sterile infections in medically treated group. Still same number of scars as I mentioned. You intervene, the scar process stops, and the numbers would remain the same, but they won't form any more. in the second half of the IRS study, I have narrated some of these findings. So, and after surgery, UTI may happen, but it is cystitis. It's not pyelonephritis anymore, for the same reason. So, we started looking at why scars form, and can we do something to reverse the process very early on, before the entire cascade of events have taken place. So, we started looking at why scars form. So, this is the pathway. This pathway is angiotensin II mediated. It has a lot of cytokines. It works through nuclear factor kappa B, and it leads to fibrosis of what is called as apoptosis. So this is what it is. I'll skip it because it's a big crowded slide, but it shows there is a documented evidence of the production of these cytokines. Another slide, how angiotensin II would cause damage. What is the source of angiotensin II in a child with VUR? Look at this pathway. Angiotensin II has formed as a result of action of ACE inhibitor on angiotensin I, on which acts renin, which is raised from the juxtanuclear apparatus, which is from a protein. So, it's a homeostatic normal mechanism. Why is it raised in VUR? That is why probably angiotensin II mediated injury is happening. We looked into this in a pilot study. It happens like this. There is reflux every time. It's water hammer effect. Pressures are generated. This apparatus gets disturbed. It's a normal homeostatic mechanism in dehydration to restart blood pressure, but it is getting disturbed, and that leads to production of renin. We conducted studies. I will not go into details. They are there in the slide, but I will tell you the gist of this. We followed up treatment on medical management. We kept on taking samples of plasma renin activity for post hoc analysis. That is, when the study ended, we will go back, what would have happened if we had gone by this. And we found this. Children who had no indications for surgical intervention as per study criteria continued to have rising levels. Where they were operated, the renin came down, which means the water hammer effect was arrested when we intervened and stopped reflux. This was the intention to cure reflux and not treat alone.
The last 2 minutes.
The last 2 minutes. Thank you. So we published this, and we skipped something which is not very central. A very good trial, Swedish trial, was conducted some days ago. We had 3 equal arms: surveillance, prophylaxis, and intervention, and they injected something called reflux to stop reflux, and they found wonderful results vis-a-vis other 2 arms. At this point, I will show you how simple is it to give injection. Let me just have it.